University, and I am the president of the Egyptian Society of Chronic Pain Management. I feel that I must share with my colleagues and my friends all over the world to think probably about pain management and to achieve an optimal modalities for treating such different and strange conditions that we face. So this presentation will be focused on how to optimize your pain management regarding diagnosis, regarding modalities, and regarding detecting outcomes. First of all, how to be optimal in any branch of medicine, not in pain management. You have to be in time in order to prevent the sequelae of acute pain mismanagement or dismanagement, such as chronic pain and chronic pain syndrome. You have to be safe. Safety is first. You can't inject septic knee. You can't inject patient with discitis, and so on. So safety is very important. You have to know the drug-drug interactions. You have to know the indications and contraindications of each drug, and so on. And you have to be effective. How to be effective? By proper diagnosis, proper decision making, skills, and training. This is very important. In order to understand the previous principles, you have to know the normal pain pathway. This is a very famous diagram showing the normal pain pathway. The pain starts by injury here, nociceptor, either it is tissue or nerve pain. This nociception or this injury will release some neurotransmitters, excitatory neurotransmitters that causes to feel pain in your cortex. But the journey will start from here, which is the first order neuron, go to spinal cord, either in lamina 2, 1, or 5, and this is the second order neuron. After this second order neuron will cross to the opposite side, ascend in the spinothalamic tract to the thalamus, which is the third order neuron, and then you will feel pain in the cortex, which is the fourth order neuron. This is the normal pain pathway. So, in order to be safe and effective, you have to treat pain at every step of this normal pathway. You have to know that this normal pathway with ascending inflammatory neurotransmitters will result at the same second, at the same moment, by inhibitory mechanisms, by neurotransmitters released from the central nervous system, go to the areas discussed above, the four order neurons, and can inhibit the release of these excitatory neurotransmitters and will add to feeling comfort from this pain. So, at the same time, ascending neurotransmitters, excitatory, there is descending inhibitory neurotransmitters. This will release these inhibitory neurotransmitters from bones, medulla, and midbrain, and in the form of enkephalins and serotonin and noradrenaline, which will release at the site of injury and will inhibit the excitatory neurotransmitters, and the patient will feel more comfort from this pain. This is the normal physiological inhibitory mechanism. So, it is by simple thinking, how to treat pain, you have to decrease the excitatory neurotransmitters, and at the same time, you have to try to increase the inhibitory neurotransmitters descending from the central nervous system to the site of injury. So we can speak about what types of pain. As I said, the pain may be from tissue pain, which is called nociceptive pain, or from nerves or central nervous system, either peripheral or nervous system, and it is called neuropathic pain. But there is a third type of pain, which is the result of some mechanisms in the body in case of not probably treating nociceptive pain, or in almost all cases of neuropathic pain, which is neuroplastic or nociplastic pain. This type of pain, it is the most resistant to treatment, and it is the most misdiagnosed by you. And when you try to treat pain effectively, you have to look after for the neuroplastic component of the patient pain. The patient pain may be nociceptive, may be neuropathic, and in almost all cases, he has neuroplastic component. Regarding chronicity of pain, we have three types. Acute pain, simply if you have acute appendicitis, if the patient has incisional injury, if he has fracture of bone, it is acute pain. If this acute pain not well treated and controlled for 3 months continuously, it will result in, and it will transform it into chronic pain, which is resistant to treatment. Chronic pain means that the pain itself becomes a disease. The severity or the magnitude of pain in chronic pain is not proportional to the injury. The injury may be small, but the feeling is too high because it is chronic. Some neurotransmitters and some neuromodulation in the central nervous system result in more feeling of pain. And I will discuss it in details. If this chronic pain not well treated, again, it will transform it into chronic pain syndrome, which I will discuss with you now, and it is the most difficult type of pain to be treated. Please, if you have acute pain, post-operative pain, traumatic pain, any form of acute pain, you have to treat it properly. There is no reason to leave the patient post-operatively, even with a small or minor injury or minor operation, to have pain. This is not allowed. First of all, it is not human. Second, it is not allowed to be chronic. If you compare acute versus chronic pain, as I said, acute pain, the cause is known, but chronic pain, the cause is unknown. There is healing of the wound, but still he has pain. Why? Some physicians who don't know the central sensitization mechanism become very angry about this and accuse the patient that he has malingering or he is not in pain. He feels pain, but there is another mechanism, not present in X-ray, not present in CBA, in complete blood picture. There is some changes in the CNS which result in feeling of pain. The duration of acute pain is short and well characterized, but chronic pain, it is persist after healing for more than 3 months. The treatment approach is the cause, and the chronic pain must treat the cause and treat the pain. The pain becomes a disease. We have modalities to treat pain. After chronic pain, the patient may develop chronic pain syndrome. What is the difference? The difference is the severe sensation of suffering of chronic pain syndrome. Chronic pain syndrome patient cannot sleep, cannot work, always anger. He tried to be isolated from his relatives. He is not happy. He can commit suicidal attempts. This is chronic pain syndrome, and this is the dangers of it. The chronic pain syndrome patient, severe suffering and has strong pain behavior. What is pain behavior? It's like that. Please remember this phase of chronic pain syndrome. The patient is groaning, sighing, crying, avoiding movement. If you try to give him attention or sympathy or care, he will complain more. This is the chronic pain syndrome, and this is very difficult to treat and needs different modalities: psychotherapy, physiotherapy, psychosocial visits. Besides that, etiological treatment. I think it's a crime to allow the patient of acute pain to be a chronic pain syndrome. If we discuss neuroplastic pain, which is an abnormal pain, not related to the intensity of the injury, of the original injury. Why it has happened? Neuroplastic pain. It may be due to peripheral generators like tissue pain or neuroinflammation. In neuroplastic pain, in the form of central sensitization syndrome, which occur in the second lamina of spinal cord. The central sensitization syndrome always in the spinal cord, spinal origin. It is secondary to the injury. The injury not treated properly, and the patient had some mechanisms of central sensitization in the spinal cord, which release more stimuli to the brain to feel pain all the time, not related to the intensity of the stimulus. On the other hand, there are some pain conditions related to central abnormal activity. We have no peripheral generator of pain, no injury, but the patient feels pain. Why? Simply of the dysfunction of the central nervous system in the form of either post-stroke or post-CNS injury, or in the form of dysfunction of hypothalamo-pituitary axial system. This is called central pain syndrome after central insult like stroke or syringomyelia or MS or any form of pain, of any form of injury to CNS. And the lesion is resolved, but the pain still. Why some patients develop this type of pain and some will not develop? It is due to central sensitivity abnormality of the patients. The second cause, which is due to dysfunction of the hypothalamo-pituitary axial system, is called central sensitivity syndromes. What is central sensitivity syndrome? The central sensitivity syndrome is defined as you feel pain without a cause. Your brain feels pain and may be localized in some points or some organs, but there is no cause, no peripheral injury, no CNS insult, but the patient feels pain. And this group of central sensitivity syndromes represent a wide range of pain syndromes we face, and almost always misdiagnosed. And all physicians of other disciplines, like orthopedics or neurosurgeons or neurologists or rheumatologists, always try to find the cause by X-ray, by labs, and they will find any cause, like irritable bowel syndrome or irritable bladder syndrome, like deep pelvic pain syndrome, all these cases will do endoscopies, will do operations, will do hysterectomies, and there is no relief of pain, and the cause is unknown. So almost always, when you find a pain patient, to exclude functional cause of pain, to exclude central sensitivity syndrome. To summarize, the neuroplastic pain mechanism may be central pain syndrome, as I said, spinal or supraspinal, and it is always secondary. Or central sensitization syndrome, it is spinal in origin, and it is secondary. And central sensitivity syndrome, it is almost always supraspinal origin, and it is primary. How we feel central sensitization? It starts by peripheral sensitization. As I said, there is injury, there is peripheral sensitization of nociceptors or peripheral nerves. This sensitization will cause spinal cord irritation with high excitatory neurotransmitters, like all pain conditions. If it is left without treatment, two mechanisms will occur, which is a sprouting of the sympathetic nervous system and wind-up phenomena. It is summation of the small stimuli to be large enough to be felt like a hill. This is the central sensitization syndrome. And so the CNS or the spinal cord becomes a nociceptive processing machine. This is the central sensitization syndrome secondary to peripheral injuries. The most common conditions we face, which may have central sensitization syndrome and almost always misdiagnosed and not properly treated, these conditions we all face, and we all inject, and we all do radiofrequency. And most of us will not think about the other mechanism of feeling pain, which is the central sensitization, like chronic pain, spine pain, like chronic post-surgical pain, post-mastectomies, post-thoracotomies, post-inguinal hernia, post-amputation, chronic arthritis, knee osteoarthritis, hip osteoarthritis, and chronic headaches. These pain conditions are primary, but if it is left without treatment or proper treatment, it may be accompanied by central sensitization and it will be difficult to treat. The management of secondary central pain must be multimodal, multidisciplinary. First of all, etiological treatment. We have to run to the etiology and try to treat. This is very important to inhibit the ongoing stimuli to the brain and to cut the circuit of central sensitization or the pathway of central sensitization. And specific pain treatment, either pharmacological or non-pharmacological. Psychotherapy is very important. Rehabilitation and physiotherapy is also very important. The patient, when he feels the patient with chronic knee osteoarthritis, when she feels that she is mobile and can go to toilet and can go to help herself, this will release her from very high percentage of pain. Rehabilitation is very important. Physiotherapy is very important in such conditions. What is the treatment of secondary central pain or central sensitization? It's either pharmacological, as I said, or non-pharmacological. Tricyclic antidepressants, gabapentinoids, other anticonvulsants, opioids, local anesthetics, NMDA antagonists, steroids, all these drugs we have to try. And I will discuss this material or this subject in another lecture. Or non-pharmacological, like intrathecal baclofen, neuromodulation, spinal cord stimulation, deep brain stimulation, and tracheotomies, surgical management. This is all under trials. And we can use both. We can use pharmacological and non-pharmacological. Always be multimodal. Regarding the primary central sensitization or central sensitivity syndrome, as I said, the patient feels pain without a cause. The most famous, you all know, is fibromyalgia syndrome and chronic fatigue syndrome. Again, chronic pelvic pain syndrome, interstitial cystitis, irritable bowel syndrome, and complex regional pain syndrome. All these are examples of the central sensitivity syndrome. When you face a patient, a female patient with chronic pelvic pain, don't think directly to endometriosis cancer. I think the patient which will come to the pain physician, I think she did all these investigations, and there is nothing to be diagnosed. She did endoscopy, normal. She did laparoscopy, normal. She did urine analysis, normal. She did all things normal. So when she comes to you, always think of functional pelvic pain syndrome. It's a functional pain and must be treated in a different way against the normal surgical or non-surgical modalities. Proper diagnosis is the key for proper treatment. In order the patient develop pain in central sensitivity syndrome, he must have genetic predisposition. As I said, if you have two patients, they did above knee amputation, they are the same age, the same sex, the same surgeon, the same injury, and do above knee amputation. One of them developed phantom pain syndrome and the other not developed. Why? Because simply the patient which developed phantom pain syndrome has a genetic predisposition. This is very important. The patient with genetic predisposition is waiting for any stress or environmental change. This will trigger the hypothalamo-pituitary-adrenal axis to represent its defect in the form of neuroendocrine, immune, and mitochondrial dysfunction, and the patient feels pain. It is hyper-excitement of different central neurons in the form of hyper-excitement of different central neurons. And the patient develops pain and suffering. So here the defect, the primary defect in CNS, and is waiting for an event or environment. And this will explain most of pain conditions we face. What is the treatment of primary central pain? As I said, it is treatment of hypothalamo-pituitary axial and mitochondrial dysfunction in form of improved lifestyle, psychological treatment, and physiotherapy, not by steroids. And I will explain it in another lecture. The specific pain therapy, either pharmacological or neuromodulation. Some drugs like pregabalin or duloxetine proved to be effective in treatment of fibromyalgia. Although it is not the sole treatment. Pharmacological is one modality. Fibromyalgia patient not treated only by drugs. It must be treated, she must be treated in a multimodal, multidisciplinary approach. As you see, the treatment barriers to be optimal, it is either due to the provider is not aware about the etiological factors of this pain, or he cannot take a proper decision for proper treatment. The patient may have some social and some psychological and some environmental problems which will resist your treatment. Although you have the proper decision, but the patient has many problems. It must be treated by another means. And the system. I mean by the system, education and the training and the guidelines. We have to have guidelines for managing chronic pain conditions. Not everyone from his mind. It is not allowed. We have to have guidelines. You have to do your guidelines, your own guidelines. When you face a chronic pain patient, put your guidelines. Is it nociceptive or neuropathic or neuroplastic? It is acute or chronic, the degree of central sensitization. It is a combined of central sensitization and central sensitivity. Please develop your own guidelines. How to be succeed, as I said, proper identification of mechanisms. We have either nociceptive or neuropathic, managing cause modalities and pathway modalities by our techniques like nerve blocks, like radio frequency, and so on. If it is neuroplastic component, it has a different modalities of treatment, and I think we have to mix this with this or combine this with this in most of cases. This will explain you the importance of multimodal analgesia. If we depend only on opioids, you will have the side effects of opioids. The most famous of this is constipation, and the opioids will be stopped. If you use only non-steroidal anti-inflammatories, the patient may develop renal failure or gastritis or peptic ulcer, and you will stop. So you have to mix drugs like opioids, non-steroidal like adjuvants, and like alpha-2 agonists and regional blocks together to be multimodal. This will decrease the dose of each analgesic, improve anti-nociceptive due to synergistic added effect, and may decrease severity of side effect of each drug. We take the benefit of each drug with minimal side effect, and we will take the benefit of using many mechanisms of action, and the local blocks and radio frequency and so on will work better. Lastly, I will remind you about the effects of non-optimal pain management. We will develop chronic pain and chronic pain syndrome, which is a very dangerous situation. The healing will be delayed, the economy of the country will be impaired, and the immunity of the patient will also be impaired, and he will be susceptible to other diseases and viruses and so on. The take-home message: please beware that there is some degree of central sensitization on almost all chronic and neuropathic pain conditions, and no effective pain management can be achieved without dealing with central sensitization component. Beware that there are many functional pain conditions due to primary sensitivity syndrome, and these functional pain conditions must be diagnosed after exclusion of all expected general or local cause, and be always multimodal, multidisciplinary.